Hi everyone, welcome to this ENT session. I hope you all are good, ready to go for this very important session on ENT. So in the next 4 days, of course we are not going to take the entire thing, but in the next 4 days I'm going to complete entire ENT that you need to know for your NEET PG exam. So just waiting for everyone to join. Now one thing, I am not watching the YouTube. So in front of me is the Telegram group that you have, that ENT doubt clearing group. So if you have any questions or doubts, please post on the Telegram group. Don't write anything on the YouTube because I cannot see that, so I will not be able to answer. So if you have any questions, any doubt, Telegram group is the place to go. So I welcome everyone, Swayam, Trivedi, Nikita, Avi Mittal, Ronak, Siddharth. So good evening everyone. Okay, so let's start with ENT. Now we all know ENT has three parts: ear, nose, throat. Usually I start with ear and then throat and then nose, in that sequence: ear, throat and nose, and I'll follow the same sequence. And I'm sure you know that in ENT anatomy is very important. The anatomy that we teach in ENT is more clinically related, so it might not be very similar to the one that we do in general anatomy, especially ear and nose. You'll find a lot of difference from your general anatomy, but this anatomy that I'm going to tell you is very important clinically actually. So let's start. Now if I ask you what are the parts of the ear, then everybody knows, every medico knows that ear gets divided into three parts. We call them external ear, middle ear, inner ear, right? And when you look at somebody's face, the only part of the ear that you can see is the pinna, and I draw the pinna like this. So guys, if you're making notes, please draw this very simple diagram that I'm going to draw. Please draw with me. So let's say this is pinna, then there is a canal called external auditory canal. Can you tell me what do you have at the end of the canal? There is a membrane here called tympanic membrane, and after the tympanic membrane there is a very small cavity. So I draw it like this, and this is the middle ear cavity. In middle ear cavity there are three ossicles, so I prefer to draw three dots like this, three ossicles. And then inner ear. Inner ear, I draw a very simplified circle. What do you have in the inner ear? In the inner ear we have cochlea and the vestibule, and we all know cochlea can be drawn something like this, coiled structure, cochlea. From the cochlea in the inner ear, the eighth nerve will carry the signal like this. Eighth nerve will carry the signal that will travel through the brain stem, and it will reach the auditory cortex, brain, where you finally hear the sound, right? Now this is a very simplified line diagram of what is called the auditory pathway. What is the meaning of auditory pathway? Pathway through which the sound travels. The sound from outside will have to finally reach the cortex to be heard and to be interpreted as sound, yes or no? And then the sound has to travel through this part, auditory pathway, which is not a very simple, it's a very complicated pathway. As you can see, this is a very simplified line diagram. Actually it's much more complicated. Now my first question is, now if the sound has to finally go from outside to the cortex, why do we have such a complicated thing? Why don't we have a simple like tunnel? If you have a tunnel like this, simple tunnel, let's say from outside to inside, the sound can go through this tunnel and reach the cortex. So why do we have so many complications in the pathway? Because the sound in the same form that we speak, the sound that is produced by any source, cannot be interpreted or understood by the cortex. You can say the languages are different, and so you need a translator. And this entire auditory pathway is making the sound or changing the sound in such a way that it can be understood by the cortex in the brain. It is changing. So the sound which is outside cannot be heard or understood by the brain in the same manner. So what kind of energy is the sound energy? While I am speaking, the sound is coming out of your phone, that if you are watching on phone. What form of energy is that? This energy is wave, and wave is a type of mechanical energy. So basically any source that produces sound, waves are coming out, sound waves, and this wave has to travel through the pinna and the canal, and they hit the membrane. And we all know when the wave hits the membrane, what happens to the membrane? The membrane begins to vibrate. We all know this. So see, this is a change. Wave has become vibration. So this is the first change that happens in the auditory pathway. Wave has become vibration. But both wave and vibrations are mechanical energy. So the thing to remember here, at the tympanic membrane, the main type of energy does not change. The subtype changes. The one type of mechanical energy, which is wave, becomes another type of mechanical energy, which is vibration. And then what happens to this vibration? This vibration that is produced in the tympanic membrane then travels through the ossicles in the middle ear and reaches the cochlea in the inner ear. In the cochlea, there is another change. What is this change in the cochlea in the inner ear? The vibration gets converted into action potential. Now, action potential is not a mechanical energy, it's an electrical energy. Now, this time the type of energy has changed. A mechanical energy has become electrical energy. And this is the most important change in the entire auditory pathway. Without this change, hearing is impossible. And this electrical energy that is produced in the cochlea then will travel through the nerve and brainstem and go to the cortex and will perceive that as sound. So these are the changes that are happening in the auditory pathway, right? So if I ask you, out of the two changes, actually the two changes are happening. One, the wave becomes vibration. The second, vibration becomes electrical energy. Which is more important change? Like I told you, the more important change is the formation of electrical energy. And if this change does not happen, then hearing is impossible. You can't hear without this change. So this is the most important change that happens in the auditory pathway. In other words, your cochlea is the most important thing for hearing. If I remove the cochlea, the entire ear is useless as far as hearing is concerned. And what does cochlea do? It converts vibrating energy into electrical energy. The type of energy changes. And when the type of energy changes, you know what process is called? What is this process called? This process is called transduction. So this is your first MCQ of the day, that what is the function of the inner ear or what is the function of the cochlea, and you say transduction. And without its change, like I said, hearing is impossible. The cochlea is a must for hearing. Now, if cochlea is the must for hearing and the most important change happens in the cochlea, then why do we need the middle ear? See, look at the diagram. Look here. If I remove the middle ear like this, the sound can still travel through this to the cochlea and transduction will happen, which is the main thing, and hearing will happen. So why do we have the middle ear at all? It's like asking, what is the function of the middle ear? And what is the function of the middle ear? This whole middle ear? Amplification of the sound, isn't it? It makes the sound louder. Amplification means louder. And loud sounds are heard better. That means middle ear helps us hear better. And inner ear helps us hear at all. Without inner ear, you cannot hear at all. Without middle ear, you can hear, but not nicely. So which is more important for hearing? Obviously inner ear, because without that you can't hear. Without middle ear, you can hear, but not so nicely, right? So inner ear is the most important thing for hearing. But if I ask you what is the function of the middle ear? Suppose if I ask you this question and you're looking for this word amplification, right? Most of the time, or most of the MCQ time, they ask you this question, that what is the function of the middle ear? Amplification, this word is not given in the choices. There's another word with a similar meaning. Anybody who knows that word with a similar meaning? That's the right word to say when I ask you the function of the middle ear or the ossicle or the tympanic membrane. Anybody wants to write that name? Let's see who knows that answer. Very important. Yeah, it is impedance matching. So this is the other name for amplification, impedance matching. Remember this name. If they ask you what is the function of the middle ear, you're going to get this word in your choices, not amplification. So the function of the middle ear or the tympanic membrane or the ossicle, same thing, is impedance matching, which is amplification, and the function of the inner ear is transduction, which means converting vibrating energy into the electrical energy. So this is what your auditory pathway does as the sound travels head on, right? So with this background, a slight physiology that we have discussed, I want to talk about the anatomy of the ear, because this was about anatomy. Yes, Siddhant, absolutely right. Impedance matching. Sai Santosh, absolutely right. Impedance matching. So when I tell you the parts of the anatomical part of the auditory pathway, I will draw another diagram, right? I don't want to make too much of hodgepodge here, so I'll draw another diagram. So let's say this is pinna, canal, tympanic membrane, middle ear, inner ear with cochlea and the vestibule. There are 3 ossicles. 8th nerve carries the signal that goes via the brainstem into the cortex. We know this, right? Now, what is this whole thing called? Common name is pinna, but you can call it auricle, which is a more biologically correct name. So auricle is what you remember for this pinna, and this is a canal called external auditory canal. External auditory canal, sometimes EAC in short. Now this, where I'm drawing the dotted line, this is like the door of the canal, or this is, you can say, the entry point to the canal. And this entry point, which is like a door, is called what? Meatus, or external auditory meatus. So meatus is like a door of the canal. Then how should you remember tympanic membrane? This one, tympanic membrane. Tympanic membrane, you should remember this as what? Meringus. Tympanic membrane, eardrum. But remember this as meringus. You can call it meringus also. And this will help you remember when I ask what is the meaning of meringoplasty or meningitis or meringotomy. So see, all these terms have the word meringo in it. So they have to have something to do with the tympanic membrane. Meringotomy. Otomy means making an opening. So meringotomy is making an opening in the tympanic membrane. Meningitis. Itis is inflammation. So meningitis is inflammation of the tympanic membrane. Meringoplasty. Plast is repair. So meringoplasty is a repair of the middle ear. So that's why these terms can be useful. And similarly, this middle ear. See, middle ear, I'm sure you know, is also called the tympanic cavity, or I will like you to remember as tympanum. Tympanic cavity or tympanum. And then you can know, if I ask what is the meaning of tympanotomy, otomy of the tympanum, or tympanoplasty is plasty of the tympanum. So if I ask you the difference between meringoplasty and tympanoplasty, you know the difference easily. That's why these terms can be very, very important. And inner ear, of course, is the labyrinth. This is a child's play. Everybody knows this. Now these are some of the terms that you have to be careful about, you should be aware about. And because these terms will keep on repeating, that's why in the beginning I like to give you these names. But which among this is the external ear, which is the middle ear, and which is the inner ear? Now this part from here till here is your external ear. External ear. And the small area is the middle ear. And this thing, of course, the labyrinth, is the inner ear, and this is how we divide the ear into three parts: external ear, middle ear, inner ear, right? Which is a very common knowledge that everybody has. Now, when I divide the ear into three parts, external, middle, and inner, like this, then this part gets left out, isn't it? This eighth nerve, brainstem, cortex, brain, all this gets left out. And we understand without this part, ear is useless. If I remove the eighth nerve, for instance, then ear is of no good, right? And that's why this whole thing has a common name. Anybody who knows the common name for this whole area? Because this area lies after the cochlea. See, it's such a logical thing. After the cochlea, it's called retrocochlear ear. Retrocochlear. See, the term means after the cochlea, retrocochlear. So for you, ear will have four parts: external, middle, inner, and retrocochlear. Now, although technically retrocochlear means everything after the cochlea, but for you and me, retrocochlear only means eighth nerve. Only eighth nerve, right? So the moment you hear the word retrocochlear, what should come to your mind? The image of the eighth nerve should come to your mind. Done? So I am very good. Avi Mittal, Yuvraj Singh Chauhan, you guys know these terms. So with this background, I will start talking about individual areas as far as anatomy is concerned. Now, if I ask you, out of these parts of the ear that I have given you here on the screen that you see, which is the most important from the exam point of view? From which area do they ask you maximum number of anatomy questions? And the answer is middle ear. Although middle ear is the smallest part of the entire ear compared to the external ear and the inner ear and the retrocochlear, if you compare all of them, middle ear is very, very small actually. But it's the most important part for you, because maximum question from ear asked from the middle ear, whether it is physiology, whether it is anatomy, whether it is investigations, whether diseases, whether procedures and surgeries, middle ear, everything is important. And you will note as we proceed, even if you have read your textbooks of ENT, you will know that almost 60% of the discussion in ear, 60% is about middle ear. External ear, inner ear, retrocochlear ear put together is around 40%, even less than that sometimes. That means we are going to spend our maximum amount of time discussing middle ear. But we'll go in the sequence. We'll go from outside towards the inside. So we'll start with the external ear, right? So if I ask you, what does external ear comprise of? What comes to your mind? What does external ear contain? And what do you say? External ear contains the pinna, auricle, canal with meatus. And what about this tympanic membrane that I'm shading with green now? Tympanic membrane is the border of the external ear and the middle ear, yes or no? And therefore, where does it belong to? Does it belong to the external ear? Does it belong to the middle ear? What do you think? Now, tympanic membrane has two surfaces. It's a membrane. There is an outer surface facing outside and there is an inner surface facing middle ear. So, outer surface of the tympanic membrane belongs to the external ear and inner surface of the tympanic membrane belongs to middle ear. That means tympanic membrane belongs to both external ear as well as middle ear. Depends on which surface you are dealing with. So, tympanic membrane also is a part of middle ear. Now, this is interesting. Why? See, I told you, let's say a plasty of the tympanic membrane which is meningus is meningoplasty, and the plasty of middle ear which is tympanum is tympanoplasty. Yes or no? Therefore, meningoplasty is a type of tympanoplasty. Meningus belongs to the tympanum, so meningoplasty is a type of tympanoplasty also, right? So that's how you remember meningoplasty is a type of tympanoplasty also. And this is important because it's going to come into play later on. So like I said, external ear anatomy is less important. So we will very quickly finish the external ear. We don't want to spend too much of time because it's less important, because we want to go to our main part, which is middle ear, quickly. But few things you need to know about pinna. Actually, only two things about pinna that you need to know. Number one, where does pinna develop from? What do you think? Pinna develops from branchial arches. Which branchial arch? Which one? First and second branchial arch. Now in ENT, there are 3 or 4 questions related to branchial arch, or 3 or 4 points you can say related to branchial arch. And as we proceed, I will tell all the important relevant ENT points related to branchial arch. But otherwise, let me tell you that branchial arch is a very, very important topic. I'm sure you, if you are following the questions in the past year's questions, you'll know that branchial arch is an extremely important topic. And almost every question paper will carry some question from the branchial arch. So my sincere advice to you is, you must read branchial arch topic as the chapter very, very nicely. It's not an easy chapter. It's the longest chapter, a lot of points to remember, but it is not an ENT topic. Branchial arch is embryology basically, or you can say anatomy. But read that, make sure that you read this chapter very nicely. Okay guys. So this is one thing. Whatever is important from the ENT point of view, I'll keep telling you related to branchial arch as we proceed. That's one point. Second thing, what is pinna made up of? Pinna is made up of cartilage, elastic cartilage or yellow cartilage, whatever, except, now this is the question, that which part of the pinna does not have the cartilage? And there are 2 parts of the pinna that does not have the cartilage. A, lobule. We all know the lobule of the pinna, which is very soft to feel, does not have the cartilage. But the second name is important that for you is called incisura terminalis. So if lobule, of course you know, but remember incisura is a very popular MCQ. Incisura terminalis. So only this much about the pinna anatomy that you have to know. Now let's say in this diagram, if I ask you where is the lobule, then obviously everybody knows this thing is the lobule, isn't it? And that's why lobule, when you feel with your finger, feels very soft, because there is no cartilage here. And this is not important, like I said. What is important is the incisura terminalis. Where is it? See, I have deliberately left a gap here. Can you see the gap here? Just above your tragus, there is a small gap. And this gap is called IT. What is IT? Incisura terminalis. And why is there a gap? Because there is no cartilage here. So this name is important, IT, for you. Now, why is incisura terminalis such an important name? Because it comes into play during surgery of the ear. Obviously, when you do surgery, you have to give incisions around the ear. And there is one incision that passes to the incisura terminalis. And because the surgical incision passes to the incisura terminalis, this is what makes incisura terminalis an important thing, right? But this gives me the opportunity to talk about what is called surgical approaches to middle ear. When I say surgical approach, what does it mean? That if you want to do surgery in the middle ear, you have to enter the ear from some area, some part. So which part will you use to enter the middle ear is surgical approach, also called surgical route or route, however you pronounce. Now, if you want to do surgery in the middle ear, there are 3 common approaches. One is called the post-oral approach. As the name tells you, we enter the middle ear from behind the pinna, post-oral. The second approach is the transmeatal approach. Meatus, remember, opening of the canal is called the meatus. So through the meatus we enter the middle ear. And the third approach is called the end-oral approach. In end-oral approach, we enter the ear from front of the pinna, right? Now in all the 3 approaches, there is an incision, and the name of the incision is a potential MCQ. Post-oral incision is called Wild's incision. Transmeatal is Rosen's incision. End oral, Lampert's 1 and Lampert's 2. These are the name of the incisions of the different approaches, and this can be a potential MCQ. So out of the 3, which one do you think passes to the incisura terminalis? the last one. Lampert's passes to the incisura terminalis. Just remember that. But Lampert's in practice is not very commonly used. So if I ask you, out of the three, which approach and incision is most commonly used for ear surgeries, the answer is first one. Actually, I have written the names in the sequence in which they are used. The first one is the most common, second one is the second most common, and end oral last one is the least common. So if first one, which is wild incision, is the most common incision for ear surgery, it must be having advantages compared to the rest of them. So that is my next question. What is the main advantage of wild incision, because of which it is very commonly used? Now, wild incision compared to the rest of the two have 4 to 5 advantages, 4 to 5. But I am interested in the most important advantage. Now, when I talk to guys in the class, face-to-face class, most people say that it has a lot of cosmetic importance, which is actually true, because as the name tells you, post-oral, the incision is behind the pinna, and so you cannot see the scar of this incision after the surgery, and the hair also grows over it, so it hides the scar. So cosmetically it is very good, but that is not the main advantage. This is the second best advantage. The main advantage, as many of you are saying correctly, that Sai Santosh and Ronak Agarwal correctly said, that the exposure is the best. The exposure of the surgical field is best during wild incision. See, if you know anything about surgery, you will know that if the area of the surgery is exposed well, then surgery becomes that much more easy, because you can identify the structures easily and surgery becomes easy and the outcome is always better. So if we are always interested in a good exposure of the surgical field, and in this case the first one, post oral incision, gives us the best exposure, and this is the main advantage. But only this much about the pinna and related points. Then we talk about external auditory canal. Now, external auditory canal, I'll tell you 6 or 7 points. Now, first I'll tell you points which are less important from the exam point of view, but you should still know them, and then I'll tell you 3 or 4 points which are very important from the exam point of view. So which are the points that are less important from the exam point of view, but you should still know them, is A, the length of the canal. The length of the canal is 24 millimeters long, 2.4 centimeters. Do you know what is canal made up of? Outer 1/3 of the canal is made up of cartilage, and inner 2/3 of the canal is made up of bone. So canal is bony plus cartilage, partly bone, partly cartilage. What is the lining of the canal? What kind of epithelium lines the canal? See, around the canal and the pinna there is skin. The same skin goes inside and lines the canal. So it is a squamous epithelium, or you can say keratinized squamous epithelium. Skin is a keratinized squamous epithelium. So canal is also lined by keratinized squamous epithelium. Now these are the 3 points which you should know, but usually they don't ask you these things in the exam, but you should know them. And then comes the main points that are very important from the exam point of view. Like inside the canal, there are few things. What are the few things in the canal? There are foramen, called foramen of Santorini. Just the names. There is a fossa called fossa of Haska. Then there are hair cells in the canal, and there are few glands in the canal. So as far as the canal is concerned, external auditory canal, these are the names that you should be aware of. Okay. Now I'll come to this one, this slide, but let me use this diagram that I drawn, the first diagram that I drawn, line diagram. Look at the canal. Now if I divide this canal here like this into two parts by drawing this dotted line, then let's say this is outer 1/3 which is cartilage, and this is inner 2/3 which is bony. Look at the cartilage part which is close to the pinna. What is pinna made up of? Everybody knows pinna is cartilage. So the neighboring area is all, this whole thing is cartilage, pinna and the canal. And inside is the bone. Actually, this whole ear, this part of the ear, this one, this lies inside a bone. And so this part of the canal is called the bony part of the ear because it's inside the bone. The whole ear, this part of the canal, the middle ear, the inner ear, they all lie inside the bone. Do you know which bone they lie inside? They lie inside the petrous part of the temporal bone. I'll show the image of the petrous bone and I'll talk about that a bit later, a little more. But remember that the petrous part of the temporal bone is where the ear is located inside. And the junction I've drawn with the dotted line. Now at the junction of this bone and the cartilage, there are few small microscopic foramen like this, 2 or 3. They are not so big, this foramen. They are actually microscopic. And these are called foramen of Santorini. Okay. They are foramen of Santorini in the canal, which are present on the anterior wall of the canal, 2 or 3 in number, and they are microscopic, so you can't see them easily. Even on a CT scan and MRI, you can't see them very nicely. Now, what is the importance of this foramen of Santorini? Tell me, if somebody has an inflammation of the external ear, what is that condition called? Most of you know, external ear inflammation is called otitis externa. We'll discuss this topic in details in a few times. Tomorrow, we'll discuss this tomorrow, otitis externa. Now, if somebody has otitis externa and there is a pathogen in the external ear, let's say this is that pathogen in the external ear and the patient is suffering from otitis externa, this is the devil. Now this pathogen devil can easily come out of this foramen easily and infect the neighboring areas. So this is why the foramen is significant clinically. It tells you that when there is a otitis externa, structures around the ear can get infected very easily. And the question is, which are these common structures around the ear that gets infected in a patient of otitis externa? And there are 2 names here. What are the 2 names? One, it can cause parotitis, parotid gland. We all know around the pinna, if you can see my face, there is a parotid gland here, parotitis. So this was the question asked once. The question was like this: why is parotitis common in a patient of otitis externa? And one of the choices said because of foramen of Santorini, and that was the correct answer. The second thing it can do, otitis externa, because of foramen of Santorini, skull base osteitis. And this can sometimes be dangerous because skull base is a very critical area, right? So this is why foramen of Santorini is important. About fossa fusca, just remember that fossa fusca is present only up to 5 years of age. At around 5 years of age, the fossa fusca disappears. But the next 2 names are very, very important in this: hair cells and glands. Hair cells and the glands in the canal are important, very important actually, because of a very important function. What is the very important function? Protection. And anything that protects us is obviously important. Yes or no? We all know that we are living in an environment, air around us, which is full of millions of pathogens. And this pathogen in the air around you is always out there to kill you because they want to feed on us. They want to kill us. But they cannot damage us most of the time because there is a lot of protection in the human body. God has given, if you believe in God, a lot of protection, and because of that we can stand like a rock, solid rock, and we are still alive. And one of the things that protects the canal are the hair cells and the glands. How does the hair cell protect? Hair cells, they filter the dust and the air of the pathogens and the particles. It's a very simple thing. But how do the glands protect? This part is important, through the secretions. And now we are going to talk about something very, very important, MCQ point of view. You have to know how many types of glands are there in the canal. What are the name of the secretions of these glands? What are the properties of the secretions of this gland? Can they cause any pathology? So all this we are going to do in the next 5 minutes. So our next 5 minutes is going to be very, very important when the exam is concerned. So first question, how many types of glands do we have in the canal? And the answer is, we have 2 types of glands in the canal. Which are these 2 types? We have sebaceous gland and we have apocrine gland. Sebaceous and apocrine. What are the secretions of this gland called? Sebaceous gland secretes sebum, and the name matches the name of the gland, so it's easy to remember. Apocrine gland secretes cerumen, and that's why apocrine gland is a type of ceruminous gland. Third point, what is the main property of these 2 secretions from this gland in the canal? They both have antiseptic property, and that's how they can kill the pathogen and therefore protect us. And the main content of these 2 secretions is fat. They are fatty in nature. So these are the things you have to know: the name of the gland, name of the secretion of the gland, and the property of these secretions. But the larger point is that these 2 secretions are always there in the canal. Yes or no? That's why if you put your finger in the canal, it always feels moist. Sometimes it also gets stained yellowish, and that is because of these 2 secretions. But canal will also always have dust particles. Obviously, the canal is open from outside, so dust can go in and out of the canal very easily. So there is always dust mixed in this sebum and cerumen. And there is one more thing in the canal, 4th thing. Normally, we are talking normal content. What is this 4th thing normally present in the canal? What is the lining of the canal? Skin. Like the rest of the body, skin is there in the canal. And one thing about skin that we know is that it constantly regenerates. The old skin dies and the new comes out. The same process is having the canal also. And therefore, the canal will have some dead skin, as Bharat says. Dead skin. The dead skin is also called keratin. The other name for it, because it's a keratinized skin, so we can call it keratin. Right? So point is that these 4 things are normally present in the canal: sebum, cerumen, dust, and dead skin, which is keratin. But these 4 things which are normally present in the canal are not supposed to accumulate in the canal. It's a cycle sort of thing that is happening. If they collect and accumulate in the canal for some reason, then it becomes a earwax. And this is a very important MCQ. They ask you, what is the content of the earwax? So if I ask you, what is the content of the earwax? You have to say sebum, cerumen, dust, and keratin. And wax carries a lot of fat. A lot of fat in it. Right? So a lot of people have a tendency to form a lot of wax. And they have to get the canal cleaned every few months. Every 3 months, 4 months they will come. You have to clean the canal and then they go back. And they get very fed up because they have to regularly visit the hospital for cleaning. And they'll ask, they will, that why do I have so much wax? My mother doesn't have, my father doesn't have, my brother does not have, my friend does not have. I have to come every 3 months, 4 months. Why? Why should I go through? What is the, can you do something permanently? Things like that, obviously. So I tell them, you are losing fat, isn't it? Compared to other people, you are losing your fat without doing any workout. Isn't it good for you? So enjoy it. Be happy. Why do you bother? People have to work so hard, treadmills and running and jogging and gym and all that to lose fat, and you are doing nothing. So you should be happy. But what do you do when there is a wax in the canal? You have to remove the wax, obviously. And the most common procedure that we do to remove the wax, which everybody knows, is syringing. Syringing is a very popular thing that we do in the clinical practice, and you must have seen syringing being done. If you have ever been to a ENT department, you probably have seen syringing being done, which is a very simple procedure. We take a syringe and we fill it with saline or water and we flush the canal basically. Now, syringing has two indications. One, of course, is the wax. Even foreign body in the canal, you have to do syringing to remove the foreign body. Now, like I was telling you, syringing at the look of it may look like a very simple procedure, but if you are not careful about few things, it can be a bad experience for the patient. Number one, you should be very careful about the temperature of the water or saline that you use for syringing. And they ask you, what is the temperature of the water or the saline that we use for syringing of the canal? And the answer is, who will answer this question? What should be the temperature of the saline or the water that is used for syringing of the canal? Can you answer this question? Anybody wants to answer that? And the answer is same as body temperature, correct. Same as body temperature, Yuvraj Singh Chauhan, correct, which is around 37 degree, isn't it? Body's temperature is. Otherwise, what will happen? Suppose the temperature is not this one, otherwise it will stimulate what? LSCC. What is LSCC? LSCC is lateral semicircular canal. Okay. And if the lateral canal gets stimulated, the person begins to have vertigo and nystagmus. And I'm sure you know that vertigo is never a good experience. That's why I say that a simple thing like differentiating the temperature can give a very bad experience while doing a very simple procedure of syringing. So you have to be mindful of these things. Now the second thing that syringing can do, it can also irritate the nerves in the canal. Now canal has 5 nerves. I will tell you the names in a little while, but if Arnold gets stimulated, one of the nerves in the canal is Arnold's, which is a branch of 10th nerve, vagus, then there is a problem. Because Arnold's branch of vagus, and vagus is the longest cranial nerve in the canal, in the human body. The longest nerve in the body is the Arnold's nerve, vagus nerve. We all know this. So, through the Arnold's, the vagus will get stimulated, and out of many things, vagus supplies two very important structures. It supplies larynx and it supplies heart. And so the stimulus reaches the larynx and the heart also. When larynx gets stimulated, the person begins to have coughing. And if in clinical practice, coughing you experience very commonly whenever you start doing something in the canal like syringing or removal of foreign body, the patient starts coughing, and you know that the vagus and the Arnold's is getting stimulated. And if the heart gets stimulated, the person goes into bradycardia, the heart rate drops, the blood supply is compromised to the brain also, and if the bradycardia is significant and the blood supply of the brain goes down significantly, then syncope can happen, blackouts. Although in practice syncope does not happen, it will not have that much bradycardia that it will lead to syncope, but theoretically there is a possibility, right? So see, a simple thing like syringing can cause vertigo, coughing, syncope, technically, theoretically at least. Coughing is not a bad thing, not a bad experience, but vertigo and syncope can both be bad experiences. And that is why what you have to remember is the cause of vertigo during syringing is different. Vertigo is because of the temperature problem, and the cause of syncope is different, which is due to stimulation of the Arnold's nerve. So you have to keep this in mind, right? Now, then we know that what is the shape of the canal? Canal is curved like this, S-shaped as we call it. If you can make the canal straight like this, then the foreign body and the wax will come out that much more easily. And we all know how to make the canal straight by pulling the pinna in which direction? Very important MCQ again. The pinna during syringing and examination of the ear should be pulled outward, backwards, and upwards. So remember this. Another very important MCQ. The pinna should be pulled upwards, backwards, and outwards to make the canal straight. And now the wax will come out, or the foreign body will come out more easily. So these are the points about the wax and syringing that you must remember. Okay, only this much about the external ear. But I told you I'll give you the name of the nerves that supply the external ear. How many nerves in the external ear? There are 5 nerves that supply the external ear. Here the name of the nerves. 5 nerves. Now 2 things here. Whenever you have to remember 5 names, A, it is not easy, it is difficult, and it is always a potential MCQ. 3 and more names are always potential MCQ. So one of the things you can do is that divide them. See this, if you divide them, like out of 5 nerves, the first 3, they all are branches of cranial nerve. They come from cranial nerve. So where will the rest 2 come from if not from cranial nerve? Which is the only other source? Cervical plexus. So one is this, if you divide them, some from the cranial nerve, some from the cervical plexus, it becomes easier. And the second thing you can do, remember, is all the 3 nerves from the cranial nerve, they all start with the letter A. So the 3 A's from the cranial nerve and the 2 from the cervical plexus are opposite of each other. One is lesser and opposite of lesser is greater. One is lesser, one is greater. So if you remember that way, it might be a slightly easy thing to remember. Arnold's, I just told you, comes from 10th nerve, isn't it? Auriculotemporal, I am sure you know, is a branch of V3 nerve, that is 3rd division of 5th nerve, mandibular nerve. And third one, auricular, is from the facial nerve, the name is given here, which is 7th nerve. So 5th, 7th and 10th nerve, they give branches to supply the canal. And then some 2 comes from the cervical plexus, lesser and greater. So that's how you remember. Okay. Now if you have a workbook of ENT, then on the first page you will see this diagram on the first page, right? And this first diagram shows you the temporal bone in the skull. The green thing is the temporal bone. Now if you remove the temporal bone only, then this is how the temporal bone looks like. The first one is the lateral view of the temporal bone. The second diagram is a medial from inside. But do you know this temporal bone is made up of 4 bones? And that's an MCQ. Which are these 4 bones that make the temporal bone? The largest part of the temporal bone is this bone. This one, which is this one. Any idea what bone is this? This is the squamous bone. Squamous is the biggest part of the temporal bone. Next bone you have to be able to identify and know the name of is this triangular bone that you see here, almost triangular. This bone, which is triangular, which can be seen only from inside, you cannot see it from outside. In the first image you can't see this bone, and this is the petrous bone. If you remember, I told you ear lies in the petrous part of the temporal bone. So that whole bony ear lies inside this particular bone only, and that's why this is the most important bone of the temporal bone. Then this bone, this last bone, this one, which is this one or this one, this is the mastoid bone. Can you name the fourth one? Siddhartha has already mentioned the fourth one. Look at the first diagram. In the first diagram, you can easily identify the bony external auditory canal. This that you see here is the bony external auditory canal, and the lower part of this canal, this is a separate bone. And what bone is this one? This one? This is the tympanic plate. Right. So these are the four bones that meet together and form the temporal bone into which ear is located. Now from here, 2 or 3 points. Number one, which are MCQs. Number one, we all know the skull bones, when they join with each other, the joints are called suture. Isn't it? Sutures. Now the suture between the petrous and the squamous bone has a name. It's a very important MCQ. It's called petrosquamous suture. What is the name of this petrosquamous suture? It is called corner septum. And they really ask you this question, that what is a corner septum? Corner septum is the other name for petrosquamous suture. That's all. Second thing, can you see in this mastoid bone, in the inner part of the mastoid bone, can you see there is a S-shaped groove here? Groove. What is this groove for? This groove is for a sigmoid sinus. Sigmoid sinus runs through this groove and then it goes out from here. There is a foramen here. It goes out and becomes the internal jugular vein. So when you follow the internal jugular vein backwards and go inside the foramen, then it becomes the sigmoid sinus and other sinuses around there. And so this bone, this last bone of the mastoid bone, which is protecting the sigmoid sinus and the lateral sinus, is called the sinus plate. It's a sinus plate because it is protecting the sinus. So in the first image, look at the first image, this bone here is the sinus plate basically. Remember the name, it will come into play later on. And like in the first example, this opening that I told you is the external auditory meatus canal. This is external auditory canal, bony canal, cartilage part has been removed. And if you look at the second image, there is another canal in the petrous bone here. And this canal, which is inside, is internal auditory meatus. So outside is external auditory meatus, inside is the internal auditory meatus. This internal auditory meatus will also come into play as we proceed. All this will happen today, right? So these are the points about this bone that you must be able to remember: sinus plate, internal acoustic meatus, corner septum. These are the types of questions they can ask you from here. And this will complete the canal. So we have done the pinna, canal, and what is inside the canal? Tympanic membrane. So now we are coming to the real anatomy that they ask in the exam, tympanic membrane, which looks like this. Now tympanic membrane also, first I will tell you these points which are less important from the exam point of view. After I tell you these points quickly, then I will talk about the main points about the tympanic membrane that they really ask in the exam. So let's first quickly complete these points. So if I ask you, what is the shape of tympanic membrane? And the answer is oval shape. Second question, what is the color? Look at this membrane image and tell me what is the color? It is called pearly white. Pearly white in color. Third point, how much is the thickness of tympanic membrane? It's a very thin structure. It is 0.1 millimeter thick. It's a very thin structure. And when it comes to the area of tympanic membrane, you have to be careful. Is it total area they are talking about or effective area they are talking about? Total area is the entire tympanic membrane, and that is 85 to 90 millimeters square. But this is the entire thing is not effective. if I ask you, what is the function of the tympanic membrane? We have discussed this already in the beginning of the day, that when the sound hits the membrane starts vibrating, isn't it? That's the function, vibration. Does the entire membrane vibrate? And the answer is no. Only a small part of it vibrates, and that becomes the effective area. How much is the effective area? It is 45 to 55 millimeters square. The effective area is different, the total area is different, and there are 4 landmarks of the tympanic membrane. What are the 4 landmarks? One is lateral process, cone of light or lateral process, handle of malleus, umbo, and cone of light. These are the 4 landmarks of the tympanic membrane, and these are the points that you should know, but nowadays they don't ask you these things very commonly, but still you should know. We'll come to the main thing here, but before that, Siddharth Dwivedi is asking, can you show the petrosquamous septum? I did not show you the petrosquamous septum, you can't see it. Petrosquamous septum is not seen like that. It's only a theory. You have to know the theory, the name, that's all. There is nothing to see there, okay? Please keep in mind that. So I hope it clarifies your doubt. Now if I look at this, coming back to the tympanic membrane, if I look at this tympanic membrane, which is pearly white, 0.1 millimeter in diameter, 85 millimeters the total area, do you know what is the boundary of the tympanic membrane called? This boundary, the boundary of the tympanic membrane is called the annulus. Remember this thing, okay, annulus. And second thing, in a normal tympanic membrane, this is a normal tympanic membrane, you can always see this ossicle. This ossicle can be seen always, all the time in a normal membrane. And this ossicle is the first ossicle, malleus. So this is your malleus, and in this malleus you can see 3 parts of the malleus. You can see this part, you can see this part, and you can see the tip point. This top part, which can be drawn like this, is called the lateral process of malleus. Lateral process. Then this part, this whole thing actually, this whole thing is called handle of malleus. So if I write HOM in future, it is handle of malleus. And the tip point of the malleus is called the umbo. So these are the 3 names that you can see always: lateral process, handle of malleus, umbo. You can always see in a normal membrane. And if you notice, I've talked about these 3 names, isn't it? And all the 3 are landmarks. Obviously, landmark can be something which can be seen. Something which is not seen cannot be a landmark, right? So I hope you can identify these things in a normal tympanic membrane if they ask you to. But now we come to the main thing. Now when I draw the tympanic membrane, oval shape, I draw it like this, roughly. Now we never draw the tympanic membrane straight like this, straight oval. This is a wrong diagram. We always draw angle like this. And let's say this is the handle of malleus, this is the lateral process. Handle of malleus, lateral process. The outer boundary is called the annulus. Now if I divide this tympanic membrane at the level of the lateral process, which is here, then this line divides the tympanic membrane into smaller upper part, this one, which is this area, and larger lower part, which is this area. These 2 parts of the tympanic membrane have names. The upper smaller part is called pars flaccida, also called the sharp nails membrane. And this is another MCQ, that what is sharp nails membrane also called? Sharp nails membrane is the other name for pars flaccida. And the lower bigger part is called pars tensa. So basically, tympanic membrane has been divided into 2 parts, pars flaccida, pars tensa. Now there are 2 questions here. If it is the same membrane, why different parts have different names, flaccida and tensa? Because if you examine or look at the membrane, they look different. Tensa means tight. So this lower larger part of the membrane looks like a very tight membrane, so tensa. And the upper, that small part, looks like very loose, dhila dhala, loose. And loose means flaccid means loose, flaccida. The look is different and therefore the names are different. And the question is, why is the look different? And the answer is, the anatomy is different. These two parts, the anatomy is different. I am sure you know that tympanic membrane has three layers, outer, middle, inner layer. Now 3 layers are present only in the pars tensa, has 3 layers. Pars flaccida has only 2 layers. So this is the difference. The middle layer is absent, which is a fibrous layer, and middle fibrous layer provides the tension of the tympanic, the membrane, and because that is gone, that is like a backbone, the tension is gone, and so it's loose or flaccid, right? So that's why they look different and the names are different. So what we had done in the beginning is that I divided the tympanic membrane into 2 parts, flaccida and tensa. Tensa is further divided into 4 parts. How do I divide tensa into 4 parts? By drawing a cross like this. If you can see my hands, cross, with the center of the cross at the umbo. Umbo is this point. So if I draw a nearly vertical line passing through the umbo and another line at right angle to this at the umbo, now you get 4 parts of the tympanic, 1, 2, 3, 4, and these 4 parts are called 4 quadrants. Quadrant come from the word quarter. 1/4 is called quarter, and from, because there are 4 parts, so very close to quarter, quadrant. Now assuming that this is the anterior end and this is the posterior end, and upper is of course superior and lower is inferior. So this quadrant, which is anteriorly and superiorly, is called the anterosuperior quadrant. Such a logical name, anterosuperior quadrant of the tympanic membrane. The one behind this becomes the posterosuperior quadrant. Below this one is the posterior-inferior quadrant, and this is antero-inferior quadrant. So tympanic membrane, pars tensa, is divided into 4 quadrants, and if I ask you what is the logic, on what basis are they divided into 4 quadrants, and it is their relative position with each other, isn't it? And why is this important now? Because each quadrant has some special points that you have to remember, and this is the main thing about the tympanic membrane that you have to know from the exam point of view, that each quadrant has some important features and you have to know them, right? So out of many points, I will tell you 5 points that you have to know. Now starting with the antero-inferior quadrant, you have to know 3 points about antero-inferior quadrant which are very important from the exam point of view. What are these 3 points? A, antero-inferior quadrant is the most common site of tympanic membrane perforation. If there is a tympanic membrane perforation, most of the time it happens in the antero-inferior quadrant. It's very important. Second important point you have to know, antero-inferior quadrant is a preferred site of a surgery procedure. Of which surgery? A surgery called myringotomy with grommet insertion. This is the name of the procedure or surgery. So if you do this surgical myringotomy with grommet insertion, then we prefer in the antero-inferior quadrant. If I ask you this surgery or procedure is done in which disease, then the answer is serous otitis media. SOME stands for serous otitis media. Now serous otitis media is a very important topic, and we'll discuss this surgery, this disease tomorrow. So when we discuss this disease tomorrow, serous otitis media, this name will come back, myringotomy and grommet and antero-inferior quadrant, all this will come back again. And the third point you have to know is that antero-inferior quadrant has cone of light. Remember, cone of light is a landmark of tympanic membrane, and that landmark is present in the anteroinferior quadrant of the tympanic membrane. So these are the 3 points about anteroinferior quadrant that you have to know. But what is cone of light? Cone of light is a cone shaped area like this, triangular area basically. Triangle, cone is like a triangle, and this is the brightest part of the tympanic membrane. It is shining as if light is coming from here, and so we call it a cone of light, and this is also a landmark of tympanic membrane. So these are the 3 points of the anteroinferior quadrant. Now coming to this posterior inferior quadrant. Posterior inferior quadrant, you have to know just 1 point. What is that 1 point you have to know? This is the preferred site of one surgery. Preferred site of which surgery? Of myringotomy without grommet. So you can do myringotomy with grommet, you can do myringotomy without grommet also, and without grommet is done for acute suppurative otitis media, ASOM. So the point is, myringotomy can be done with grommet or without grommet. For both these situations, the site is different and the indications are also different, and that's why sometimes you get confused between the two. So it's very simple, straightforward. Try to remember this, and they ask you this really commonly, so don't get confused. Okay. And the last point I want to tell you is related to the posterior superior quadrant, this one. Posterior superior quadrant is the most common site of traumatic perforation. Perforation due to trauma. Traumatic perforation happens posterior superiorly and posterior part of the tympanic membrane. And this traumatic perforation, the shape is also different like this. Like this is the shape. So it is more long, so we call it oblong shape. Otherwise, most of the perforations are round to oval in shape. When we do CSOM, I am going to show you many images of tympanic membrane with perforations. Don't worry, I'll show them tomorrow, of course. And you realize that most of the perforations on the tympanic membrane are either oval or roundish or thereabout. But this perforation is very different. It is oblong and the site is different, posterior superiorly mainly. And so traumatic perforation is very easy to identify and diagnose. And you know why it's so important to diagnose traumatic perforation? Because they ask you the treatment, and the treatment is conservative management. You don't have to do anything. 95% of traumatic perforation, they will heal within 1 to 2 weeks without any treatment. Tympanic membrane is very good at healing. It heals really well. So don't do anything. This will heal. That's why it is important. So these are the points. This is the slide that is important for you from the exam point of view. If tympanic membrane questions are asked, it is going to be from here most likely. Is it tough? Not really. Do you need to remember? You have to be able to remember this, right? Now look at this image of the tympanic membrane perforation, and this is also given in your book, the notebook that is provided, right? So very quickly we have come to the middle ear, which is the main part. So I've done very fast because I want to talk about this thing. What is this? Middle ear anatomy. Now here I'm going to spend some time with you guys. Very, very important. Are you ready for a very important anatomy that are likely to be asked questions from? Now tell me, if I ask you what is the shape of the middle ear, suppose, then you have to say the shape of the middle ear depends on the view. Are you looking at the middle ear from the front? If you're standing in front of me, and if I take a coronal section of my ear, coronal section, then it is biconcave. Don't draw this. Even if you're making notes, don't draw this. Biconcave, middle ear looks like this from the front. There is a concavity from both the sides, and therefore it's called biconcave cavity. But if you look at the same middle ear from the side, sagittally, if you're standing on my right side or left side, and you cut the ear sagittally, then it is called ovoid or a cuboid, something like this, almost like an egg, you know, almost like an egg, right? See, look at the two images, that diagram that I've drawn. Middle ear, two different views, they look so different from each other. That's why the shape of the middle is very difficult to define. It means that if you take a middle ear and starts rotating it, the shape will keep on changing. And that's why it is very difficult to define the middle ear shape. And therefore, we have compared the middle ear to, as Ronak says, matchbox. It is like a matchbox. It is compared to a matchbox. Why is middle ear compared to a matchbox? Like a matchbox or like any other box, middle ear has 6 boundaries. Like the room that you are sitting in has 6 boundaries. On top of you there is a floor, roof. Below you is the floor. Assume the wall in front of you, the wall that is facing you, is the anterior wall, lateral wall, outer wall. So the wall behind you will be the inner wall, medial wall. On your left side is the anterior wall. On your right side is the posterior wall. 6 boundaries. That's why it is compared to a matchbox and something like this. So when I draw the middle ear like a box, I draw it like this. And this diagram is given in your notebook also. I've given you. This middle ear, which is like a matchbox, has 3 compartments. How do I create 3 compartments? If I draw 2 lines like this, now there are 3 compartments: upper 1/3, middle 1/3, and lower 1/3. And if I ask you what is the main content of the middle ear, then there are 3 ossicles in the middle ear: malleus, incus, and stapes. Everybody knows that. So middle ear has 6 boundaries, walls, 3 compartments that I have drawn in front of you, and there are 3 ossicles. But along with 3 ossicles, there are 2 muscles and 2 nerves also. So we'll discuss all these things. We'll discuss all the 3 boundaries, all the 6 boundaries. I'll tell you the name of the 3 compartments just now. We'll talk about the 3 ossicles, the 2 muscles, and the 2 nerves. So when I say the anatomy of the middle ear, these are the things that we have to talk about in the next around 1 to 1.5 hours. Very, very important, right? Now, first thing, the name of the 3 compartments. The upper compartment is called what? Epitympanum. Epitympanum is the upper part of the middle ear, also called attic. Same thing. The middle is called mesotympanum, T for tympanum, and the lower part is called hypotympanum. Okay, so these are the 3 parts of the middle ear: epitympanum, mesotympanum, hypotympanum. And then we'll talk about boundaries. And to talk about boundaries, I will use another image or diagram. That's why in your book also, I have provided 2 diagrams like this so that it does not get hodgepodge. If you write the same thing in the same diagram, everything, then there is too much of a confusion. Now, before I can discuss these 6 boundaries of the middle ear, I have to add the external ear and the inner ear also. So how do I add the external ear? If I draw the canal like this, let's say this is the canal and this is the pinna, right? So on the other side, I will draw the inner ear, which should be like this. This is inner ear with cochlea and the vestibule. So look here, this diagram is very similar to the first diagram that I had drawn when we started. The only difference is the middle ear this time is shown like a box, otherwise external ear, middle ear, inner ear. If I tell you, you know one boundary already in this diagram, which is the boundary that you know already? You know this boundary, which is outer boundary, because it is facing the outer ear. If you're writing the notes, don't write this, don't write, make the diagram but don't write. So if this is the outer boundary, this inside becomes the inner boundary towards the inner ear. This upper boundary is obviously the roof, and below will be the floor, isn't it? The one in the front, let's say this one, is the anterior boundary, and the one behind is the posterior boundary. Isn't it? 6 boundaries. There is a roof, there is a floor, there is outer, there is inner, and there is anterior and there is posterior. So that's a very easy thing. Now, if I tell you, you know one boundary already, you know this outer boundary, because we just discussed that outer boundary of the middle ear is made up of tympanic membrane. Remember, tympanic membrane is like a border between the external and middle ear. So outer boundary, I should draw like a membrane like this, with the handle of malleus, lateral process and the cone of light like this. Basically, whatever we discussed about tympanic membrane just now is applicable to every on the outer boundary of the middle ear. Everything is the same. Obviously, that means one boundary you know already. Then inner wall which is opposite of the outer wall is not straight like it is shown. In the center here of this inner wall, there is a very prominent bulge like this. It's bulging almost like this. So this is how we draw the inner wall of the middle ear. It's not straight. And this bulge has a name. This bulge on the inner wall of the middle ear, anybody who knows the answer, is promontory. Now the question is, why do we have a promontory here? Because of the promontory, extra space gets created in the inner ear here, and in that extra space something will fit there. It wants to fit something, and what is that something that needs to fit in this extra space? This cochlea is like this, and this part of the cochlea is called the base of cochlea. So if I ask you, why do we have the promontory in the middle ear, in the inner wall of the middle ear, you have to say, so that deep to it can fit the base of the cochlea. There is space for the base of the cochlea, right? Then roof has a name. This roof has a very popular MCQ also. It's a very simple thing, but they ask you, it's called tegmen tympani. Tegmen tympani is the name of the roof of the ear. Only the name is important, nothing else. Okay. And below the floor, this is the floor, below there are two important things, and they both start with J. So I call them two jokers. There are two jokers below the floor. One is Jacobson's nerve. This is the name of a nerve, and jugular vein or jugular fossa, jugular bulb, jugular vein, whatever. See, out of 6 boundary, you know 4 boundaries already. You know that outer boundary is tympanic membrane, inner boundary has a bulge called promontory, roof is called tegmen tympani, and below the floor there are two jokers, jugular vein and Jacobson's. And we have to talk about anterior wall and posterior wall. Actually, anterior wall and the posterior wall are the most important walls of the middle ear that you have to know. So we are still to discuss the most important boundary of the middle ear, right? Now before that, this Jacobson is very important. You know why Jacobson is important? Jacobson is a nerve which is a branch of 9th nerve, and this enters the ear through the floor. Enters where? Middle ear. And what is the other name for the middle ear? Tympanum. Remember, I told you middle ear can be remembered as tympanum. So it enters the tympanum to the floor, and once this nerve enters the tympanum, it forms a plexus in the tympanum, and that plexus is called tympanic plexus. And it is this tympanic plexus that supplies the entire middle ear. So which nerve supplies the middle ear? Tympanic plexus, which is formed by the Jacobson branch of the 9th nerve, and it enters the ear to the floor. So these are simple things that you must remember. See, external ear had 5 nerves, difficult to remember, but middle ear has only 1 nerve, very easy to remember. Okay. So remember, I was telling you we'll discuss 3 ossicles, 2 nerves. One of the nerve is tympanic plexus in the middle ear. One of the nerve is this one, right? So we know about 4 boundaries already. We need to talk about 2 boundaries. Now before I talk about the remaining 2 boundaries, which are very, very important, I want to talk about this tympanic membrane a little bit more. So tell me, how many layers tympanic membrane has mainly? I told you in the beginning, tympanic membrane has 3 layers, isn't it? At least in the past tense, flaccida has 2 layers. Meaning, if you cut the tympanic membrane and look at the cut end of the tympanic membrane, you should be able to see three layers. Let's say these three layers are like this: outer layer, middle layer, and inner layer. There's no gap there. We have to show gaps. When we draw layers, we have to show gap so that you can appreciate they are trying to draw layers, but actually they are touching each other, and the total thickness is 0.1 millimeter, which I told you before. And from this diagram we understand that this area is the pars flaccida area because there are two layers, and below this area is the pars tensa area because there's three layers. So this is a tympanic membrane. Now if I add the external ear like this is the external ear, let's say, and a pinna, and let's say this is the middle ear, and this is your inner ear with the cochlea and the vestibule like this. Again, a very similar diagram that I had drawn before, the line diagram, only this time the middle ear is shown like the three layers. Middle ear is shown in three layers. Now in the middle layer there are three ossicles. There is malleus like this. So malleus we draw like this, malleus. Then second ossicle, incus, can be drawn like this. These are incus. And then there is a stapes. Stapes can be drawn like this. This is how we can draw the three ossicles of the middle ear. Right. And at the end of the stapes, there is a foot plate of the stapes. So let me draw a foot plate also here. Something like this, three ossicles. So we have the middle ear, tympanic membrane with three layers, pars flaccida, pars tensa with three ossicles. Now I'll come to this diagram. I've drawn this for a reason, but this is how the ossicles will look like. So obviously this is your malleus, this is your incus, and this is the stapes, and this is the foot plate of stapes. This diagram is given in your, this image is given in your notebook, workbook. Now from here we have to know two things. Malleus and incus, they develop from first branchial arch. First BA is branchial arch, and this part of the stapes develops from second branchial arch. But as far as ossicles are concerned, this is less important. What is very important, extremely important actually, is where does the foot plate develop from? This is an extremely important MCQ. Anybody who wants to answer this question, because it's a very commonly asked question, where does the foot plate of the stapes develop from? Who will answer this question? Please write in the notes, in the comment. Foot plate of the stapes comes from where? Anybody? Yes, otic capsule. So very important MCQ, foot plate develops from otic capsule. So this is one thing you have to know in this image. The second thing, if there are three ossicles, how many joints will we have? If there are three ossicles, there will be two joints. One is this joint between malleus and incus, and the other is this joint between incus and stapes. And the question they ask you is, what type of joints are these? So what type of joint is the joint between malleus and incus? This is a saddle joint. Now saddle joint was asked last November INI set exam. In the last November INI set exam, they had shown an image of the middle ear with ossicles. They had pointed at this joint and asked what type of joint is this? Saddle joint. Very simple. And what type of joint is the joint between malleus, incus and stapes? The second one, that is ball and socket joint. And this is what Yuvraj Singh Chauhan is telling you, ball and socket joint. Now, if you have been following the past years MCQs, we'll know that this type of question, the joints, this type of question in the last 15 years have been asked 3 times. They have asked this 3 times. 2 times they've asked this joint. Long back. They've not asked this question for a very long time. And then suddenly last year there was a question, and this time they asked about a different joint. They asked about this joint. So indirectly, it means that both the joints are important to remember. It's a very simple thing to remember, but must remember this. Now, if you take the CT scan of the temporal bone, this is how a CT scan looks like. Again, this is given in your note workbook. In this CT scan of the temporal bone, can you identify the middle ear? Middle ear. Which is the middle ear? If you remember, I told you middle ear is a very small cavity. And this small cavity is the middle ear cavity. It's a very small cavity. And then inside of this area is the inner ear. Inner ear. Now compare the size of the middle ear to the inner ear. Inner ear is 4 to 5 times bigger than the middle ear. This I don't have to tell you, everybody knows, because the air cells, multiple air cells, this is mastoid. So in a temporal bone CT scan, you should be able to identify the middle ear, the inner ear, and the mastoid easily, which is not difficult. Now look at the middle ear. In the middle ear, what is this white things that you see? These are the ossicles. These are how the normal ossicle in the middle ear look like. Now this look of the normal ossicle in the middle ear is described as ice cream cone appearance. Ice cream cone. Normal ossicles. Does it look like an ice cream cone? For any sign and thing, you have to have a bit of imagination. Anybody who named this, according to that person, this is a cone of ice cream, and on the cone of ice cream, this is a scoop of ice cream sitting on it. So that is a logic by after naming this ice cream cone appearance. Remember this. And if you cannot see this typical look of the ice cream cone appearance, that means the ossicles are damaged or diseased. That's the importance of this name. Okay. So coming back to this one, you can see the malleus incus and the stapes. Now I told you that although tympanic membrane has 3 layers, which is shown in your diagram here, but actually they look like one layer. They all joined, fused into each other. So I must draw like one layer. So I will draw this like this, one layer. This is the roof, this is the floor, and this is your promontory and the inner ear, right? Now if you look at the middle ear now, the way I have drawn it, you understand now very nicely why it is called a biconcave cavity. It looks like a biconcave because of the curve of the tympanic membrane and the bulge of this medial wall. Now I have drawn this diagram so that I can explain 2 things which are very important. On the anterior wall of the middle ear, there is a tube like this, station tube, and we all know the station tube is there to balance the pressure in the middle ear. We will discuss this in details. Now it is very common for the station tube to get blocked. If the station tube gets blocked, now they cannot balance the pressure in the middle ear, and this leads to negative pressure in the middle ear. Now negative pressure in the middle ear is a very common occurrence in our body. Every time you have a rhinitis, sinusitis, cold, or every time you travel in a flight, when the flight is going up and down, like in these monsoons, if you have traveled in monsoon in India, the flight really goes up and down and the pressure will keep on changing. So what does negative pressure do? Negative pressure has a tendency to pull. It has a tendency to pull. It pulls what? It pulls the tympanic membrane from here inward in this direction, and the membrane will come here. It gets pulled inside like this. And when this happens, this is called retraction of tympanic membrane. So this is the meaning of retraction of tympanic membrane, where the tympanic membrane has been pulled inward. So if you see a tympanic membrane is retracted, it tells you two things. It tells you this definitely means the middle ear has a negative pressure. Indirectly, this tells you your Eustachian tube is having a problem. And if the Eustachian tube is having a problem, it is either because of cold and rhinitis, things like that, or maybe person is traveling, in the flight and all that. So these are the information that you get from the retracted tympanic membrane. But look at the diagram that I have drawn. The way I have shown the tympanic membrane retraction, although it is retracted, it is still not touching this incus the way I have drawn. It is not touching the stapes. It is not touching the promontory also. So when this happens, it is retracted, but it is not touching the incus and the stapes and the promontory. This is called grade 1 retraction. Grade 1. If there is more severe retraction, it goes more inside. Grade 2. What happens in grade 2? It comes like this. Grade 2. See, now it is touching the incus and the stapes also. Grade 2, but not the promontory. So that is what happens in grade 2 retraction. And if it touches this promontory like this, let's say like this, then it becomes grade 3. Now see, grade 3, it is touching the promontory. So basically, I drawn this diagram so that you can understand and remember the grades of the tympanic membrane retraction. What is grade 1, grade 2, grade 3. And because this is asked in the exam very commonly, they've already asked question related to the retraction of the tympanic membrane 2 times in your NEET PG exams in the last 10 years. So look here, this is given in your book also, no workbook. You strike off the grade 5, it is not important. So look at the grades that I've told you. There are 4 grades actually. See, grade 1 is slight retraction, not up to incus. Grade 2 is up to incus-stapedial joint, but not promontory. Grade 3, it touches the promontory, but in grade 4 it is adherent onto the promontory. So in grade 3 it is just touching, but in grade 4 it becomes permanently attached to the promontory. So it's very easy to remember the grades. Please remember, because they ask in the exam, and they've already asked the name of the person who gave the grading, and the name is SADE, SADE. So this is called SADE grading of tympanic membrane retraction. So that's why this is important. So this is one thing that I wanted to explain with the help of the diagram. So let me remove these grades. Now the second thing that I want to explain is this. See, in this diagram, if I ask you what is this part, so obviously you will say that this is pars flaccida of the tympanic membrane. The top part is pars flaccida, sharpness membrane. This part of the malleus is the neck of malleus. Now from the neck of malleus to the pars flaccida, there is a ligament going like this. Now this ligament, which is traveling from the neck of malleus laterally to the pars flaccida, is called lateral because the direction is lateral, and because it's starting in the malleus, malleolar fold. It's called lateral malleolar fold. Now in this particular diagram, there are 3 names that I have written. What are the 3 names? One is lateral malleolar fold, the second is neck of malleus, and the third is pars flaccida. Can you see between the 3 there is a space? There is a space here, very small space. This space is very special and it has a name. What is the name of this space? This space is called Prusak space. Prusak space, very important space. So can you see that diagram, Prusak space? Now Prusak space you have to know two things. A, the name of the three boundaries, which is very simple now. So tell me, what is the superior boundary, what is the inner boundary, and what is the outer boundary? Superior boundary of the Prusac space is lateral malleolar fold, isn't it? Very easy now. Inner boundary, what is inner boundary? Neck of malleus. And outer boundary, obviously pars flaccida, but remember, outer boundary has one more thing called scutum. Just remember this name. I'll show you the image later on. So these are the three boundaries of Prusac space. Very important MCQ, very commonly asked. And the second thing, why is Prusac space important? Because it's the most common site of a very popular disease. Which disease? Anybody? Which is the disease that very commonly arises in the Prusac space? And the answer is cholestoma. Cholestoma is a very popular disease of the ear. There are a lot of points and questions from here, but we'll discuss this disease later on, maybe tomorrow. We'll discuss about this. Then when we discuss cholestoma, I will ask you then that where does cholestoma most commonly arise from, and you should be able to say then it arises from the Prusac space, right? So this diagram I had drawn so that A, you can remember the boundaries of the Prusac space very easily, and B, you can remember the grades of the retraction of tympanic membrane also easily. That was the aim of drawing this diagram, right? And now I want to talk about the remaining two boundaries. Which are the remaining two boundaries? Anterior wall, posterior wall. I told you these two boundaries are the most important boundaries of the middle ear, the anterior wall and the posterior wall. Let us start talking about this boundary. Now tell me something. When I do otoscopic examination and when I look at the middle ear from outside like this, which is the only boundary of the middle ear that I can see, obviously I can only see the tympanic membrane, which is the outer boundary. Rest are all obscured or hidden by the tympanic membrane, isn't it? Now suppose I remove this tympanic membrane. Now there is no tympanic membrane in the middle ear. Only 5 boundaries are left like this. If I now see from outside otoscopy, which wall is right in front of me? Inner wall obviously, and the promontory is right in front of me. Top there is a roof, below there is a floor. On the one side there is anterior wall, one side is posterior wall, right? Obviously. So this middle is like a box, any box that you see at home. And if you remove one boundary, in this case the lateral boundary, the tympanic membrane, 5 boundaries are left. And when I open this wall box, if you open any box with 5 boundaries, how does that open box look like? Can I draw it like this? Isn't it? So this is how the open box should look like. Now we cannot open it practically, but for theory we have to do these kind of things, right? So this is your open box of 5 boundaries and 1 boundary is gone. This diagram is given in your notebook also. You can use that. Now don't write what I am writing now. So this becomes your roof obviously. This becomes your floor, and this is your inner wall, also called medial wall. So one has to be anterior wall, one has to be posterior wall, and the outer wall, which is tympanic membrane, is assumed to be removed. And we also know that this inner wall has a bulge called promontory, and in this diagram I draw the promontory like this. So this is your bulge right in the center, and this is supposed to be your P for promontory, right? Roof, I don't have to tell you anything. Name is tegment tympani, we have done that. Floor, I don't have to tell you, there are 2 J's, jokers just below this, jugular vein, Jacobsons. So we mainly have to talk about this anterior wall and this posterior wall. Now before I start talking about the anterior wall and the posterior wall, if you remember, I told you that below the floor, one of the J like this is the jugular vein, jugular bulb like this, IJV. So below the floor is the jugular vein, and anterior to the anterior wall is a artery running like this, and this artery is internal carotid artery like this roughly. So why I've drawn these two great vessels, so that you understand that very close to the middle ear there are two great vessels, artery and vein, the main artery and the vein in the body, and they're very close to each other like this. But both these are outside the ear, they are not related to the middle ear anatomy, they are outside, close by, they are neighbors. So I'm going to remove that. I have to talk about what are the structures on the anterior wall. So we'll start with anterior wall. So what are the things on the anterior wall of the middle ear? Anterior wall has two openings. One is a small opening like this, and below that there is a bigger opening like this. That's all. What is this small opening on the anterior wall of the middle ear? This opening is called what? It's called canal for tensor tympani muscle. See? So what do you understand from this name? You understand this is a canal through which a muscle enters the ear, and the name of the muscle is tensor tympani. Obviously. See, when I was telling you we'll discuss three ossicles that we have done already, two muscles and two nerves, this is one of the muscles that we have to discuss. Only the name is important. Okay. But the bigger opening, this opening is very important opening, and everybody knows this opening. This is the Eustachian tube opening, isn't it? Now Eustachian tube is a very popular MCQ. They ask you 3 to 4 very common questions from the anatomy of the Eustachian tube, and let us discuss that anatomy. But before I start the anatomy of the Eustachian tube, these are the two things, canal for tensor tympani muscle and the Eustachian tube on the anterior wall. But talking about Eustachian tube, we understand it's a tube like this roughly, and any tube has two ends obviously. So Eustachian tube will also have two ends. One end, as you can see, lies on the anterior wall of the middle ear. Where does this other end of the Eustachian tube open? Anybody who wants to answer this? Where does the other end of the Eustachian tube open? And the answer is, it opens on the lateral wall of the nasopharynx. Lateral wall of nasopharynx. Now nasopharynx is pharynx behind the nose. Pharynx we'll discuss day after tomorrow, but when I will discuss pharynx like this, I'll draw the pharynx like this. Okay, this is, let's say, the pharynx, and this entire posterior column that I am drawing now is the pharynx actually. And because it's a big pharynx, it is divided into three parts like this. All this we'll discuss in details day after tomorrow on Saturday. So don't worry, I'm just telling you. And this is the nose, we all know, and behind the nose is the nasopharynx. And if you look into the nasopharynx, you will see the Eustachian tube opening is drawn like this. This is how we draw the opening of the Eustachian tube in the nasopharynx. So this end is actually this end. So when you look into the nasopharynx, you can see the Eustachian tube like this. And when you look into the Eustachian tube in the nasopharynx, one more thing you will notice, there is a bulge around and behind the tube like this, bulging something here like this. In this diagram, something is bulging like this in the Eustachian tube. And what is this bulging thing in the Eustachian tube in the nasopharynx? It is called torus tubaris. The name of this bulge is torus tubaris. Torus is a bulge, it is related to the Eustachian tube, so tubaris. Now comes a very, very important MCQ. Bharat is correctly saying torus tubaris. What is the cause of torus tubaris? This is a question. Torus tubaris is caused because of three muscles which are attached to this end of the Eustachian tube. So this end, which is the cartilage of the Eustachian tube, has three muscle attachment, and because of them this bulge called torus tubaris is formed. And they ask you the name of the muscle, tensor veli palatini. So as the name tells you, this is a tensor of the palate. And the second is also palatal muscle, levator palati. Both are palate muscle, and the third muscle is pharyngeal muscle called salpingopharyngeus, and this is MCQ. The three muscles which are responsible for the formation of torus tuberis, two are palate muscle, one is a pharyngeal muscle. Easy to remember, not a difficult thing, because these muscles are very popular muscles, I'm sure. So with this background of the station tube, now I'll tell you 3 or 4 very commonly asked questions. But I'll remove this part which is not required now. So what is the length of the station tube? Anybody? This is a simple thing, 36 millimeters long is the length of the station tube. What is station tube made up of? If I ask you what is the canal made up of, external canal which I am pointing in my canal made up of, if you remember, I told you outer 1/3 is cartilage, inner 2/3 is bony. Station tube is opposite of that. Opposite means outer 1/3 is bony of the station tube and inner 2/3 is cartilage. So opposite of the canal, that's how you remember opposite of the canal. Third point you have to know is how is the station tube of a child different from adult? Very important point. The station tube of the child as compared to adult is shorter. Obviously, children will have shorter, everything is shorter compared to adult, but it is wider and it is straighter. The third point is the most important point, the fact that station tube of a child is straighter as compared to adult. Straighter means it is less horizontal. In adult, the station tube is inclined, and in children it is less inclined, more horizontal actually. So that's called straighter. And what is the significance of this question that the child's tube as compared to adult is shorter, wider and straighter? Because of this anatomy, difference in the anatomy of the station tube in children, the infection of the nasopharynx, this nasopharynx can easily go through the station tube in children and come inside the ear and cause otitis media. Otitis media is always because of the station tube problem. And the question is, why is otitis media in children more common as compared to adult? The otitis media, which is infection of the middle ear, is more common as compared to adult because the station tube of a child is different from adult. How is it different? It is shorter, wider, straighter, and that's why this is such an important MCQ. And the last point you have to station tube, what is the function of station tube? It has two functions. One I told you already. It will balance the pressure of the middle ear. Balance air pressure in the middle ear. But it is also for drainage of secretion. So two functions, balance of pressure, drainage of secretion are the two functions of station tube. Now I told you, if you remember, station tube in the nasopharynx gets blocked very commonly. Every time there is rhinitis, sinusitis, flight and all that, it gets blocked. And if the station tube gets blocked, both the function get disturbed. It cannot balance the pressure, it cannot drain, and if it cannot balance the pressure, I already told you it causes negative pressure. And negative pressure in the middle ear happens within few minutes. If the station tube is blocked now, within 5 to 10 minutes, it will start creating a negative pressure. It's a very instantaneous thing. But when drainage also gets affected, then there's a collection of fluid in the middle ear. Obviously, if the drain of your bathroom gets blocked, then the water starts collecting in the bathroom. Yes or no? But this will not happen immediately. This will only happen if the station tube is blocked continuously for at least 3-4 days minimum. So negative pressure happens immediately, but collection happens after few things. So if somebody has a collection of fluid in the middle ear, you know one thing, that their station tube is blocked for at least 3-4 days. Right? What does negative pressure do? It does two things. One, I told you, retraction of tympanic membrane. And retraction, grading we discussed. We know it is done by, grading is done by a person called SAD. All that we have done already. So we know that. But it can also cause barotrauma. Baro is pressure. Trauma due to sudden change of pressure. So in the flights, when you experience that ear pain or hearing loss, that is called barotrauma actually. And the question they ask you is, barotrauma is more likely to happen when the flight is going up or flight is coming down. What comes to your mind? When will barotrauma more likely happen? Ascending or descending? And the answer is descending. When you're coming down, barotrauma is more likely to happen. And the last thing is, when there's a collection of fluid in the middle ear because of blockade of the tooth for many days, this fluid gets infected and now there's an infection of the middle ear which is called otitis media. And otitis media is a very ear topic that we will discuss tomorrow. So see, a simple thing like blockade of the eustachian tube can cause three problems. It can cause retraction, it can cause barotrauma, it can cause otitis media. And these are the points about the eustachian tube and the anterior wall that you have to know. Simple points, but very important points. So anterior wall of the middle ear, done. Next, which wall? Actually, before posterior wall, I want to talk a little bit more about this inner wall, which is medial wall. So inner wall, which is medial wall, is what we are going to discuss. And in this wall, you already know one thing. If I ask you what is the one thing that you know already, obviously you'll see I know there is a bulge in the center called promontory. It is shown in the diagram also. But do you know that medial wall of the middle ear has one more bulge? That means total of two bulges. And there are two windows also. And there are two more things. So I suggest that we remember the inner wall of the middle ear like this: two bulges, two windows, two more things. One bulge you know is promontory, and it's shown also. The second is called bulge of LSCC. Remember LSCC? Lateral semicircular canal. So there is a bulge of the lateral canal also on the medial wall of the middle ear. And in the diagram alongside, if I have to draw this bulge of the lateral canal, where do I draw it? Look at the diagram in the top corner here, like this. I draw it like this, the bulge of the lateral canal. So this is your bulge of the lateral canal. And never disturb this bulge, because if you disturb this bulge, the patient will start having vertigo and nystagmus. And this is what happens if you do the syringing without taking care of the temperature. If the temperature is not 37 degree during syringing, then this bulge gets stimulated and the patient begins to have vertigo and nystagmus. We know this, isn't it? So it has a lot of significance. Two windows everybody knows. Which are the two windows? One is called oval window and the other is called round window. And I don't have to tell you, the name is given because the shape is like that. One is oval shaped window, oval window. One is round shaped window, round window. But where are they located? Look at the diagram. Oval window, I draw it here. See, oval shaped window, I have drawn deliberately oval shape. And round window, I draw here, round shape, roughly. So the point to remember is that oval window is towards the upper part of the promontory and round window is towards the lower part of the promontory, and both are very close to the posterior wall, isn't it? Like I've drawn. And finally, what are the two more things on the inner wall? One is a facial nerve, seventh cranial nerve, facial nerve, and the second thing is called fistula antefenestrum. So these are two in the medial wall of the middle ear, two bulge, two windows, two more things, Very easy to remember. But where do I draw the facial nerve? In this diagram, if I have to draw the facial nerve, it is just above the oval window. You can see the oval window in the diagram. Now look at the diagram. I draw the bulge of facial nerve like this. It is running in this direction, right? And this part of the facial nerve is called the horizontal part of the facial nerve because it is running horizontally, and see, it comes on the posterior wall. From the medial wall, the facial nerve comes on the posterior wall. Now when the facial nerve comes to the posterior wall, what happens to this nerve? On the posterior wall, look at the diagram, the nerve will turn and run down and go out of the ear like this. And this part that I have drawn now on the posterior wall is called the vertical part of the facial nerve. That means in the middle ear, facial nerve has two parts. In the medial wall, just above the promontory is the horizontal part. In the posterior wall is the vertical part, and it comes out of the ear. And remember, I was telling you there are two nerves in the middle ear. This is one nerve, facial nerve. The other nerve I mentioned already is tympanic plexus that we mentioned, right? Now, why is fistula antefenestrum important? Fistula antefenestrum is important because it is the most common site of a very popular disease called otosclerosis. Otosclerosis is another very popular disease of the ear. We are going to discuss this tomorrow. And if I ask you where does otosclerosis most commonly arise, then fistula antefenestrum. Where is it? Look at the diagram. If it is in front of the oval window, a small opening here like this, I am showing with the arrow. Look at the arrow on the medial wall of the middle ear. You can see a small opening anterior to the oval window. That opening is called fistula antefenestrum. Otosclerosis starts here. Right. So these are the points about the medial wall of the middle ear, 2 to 2. And final wall is the posterior wall. For posterior wall, I will use another diagram, this one. That's why I have given you two images, diagrams in your book, so that the first one you can use for anterior wall and the medial wall. The second image you can use for posterior wall. So this is your posterior wall now. In the posterior wall of the middle ear, one thing you know already, one thing that you know already is the facial nerve. Yes or no? Seventh nerve. And look at the diagram or the image. The facial nerve is coming out of the ear. So if any nerve is coming out of anywhere, there has to be a foramen here. So there is actually a foramen here through which the facial nerve comes out, and this foramen has a name. This foramen is called stylomastoid foramen. So remember this, facial nerve comes out of the middle ear through a foramen called the stylomastoid foramen. Right. That means the lower part of the posterior wall has a foramen and the upper part has a door like this. Door. Yes, Avi Mittal, you are right. Stylomastoid foramen. What is the name of this door? This door is called adytus. So the name of the door is adytus on the top of the posterior wall. Normally doors are on the lower part of the wall, but this door is on the top of the wall. चोर का दरवाजा, चोर दरवाजा ऊपर होता है, normal doors are lower. How many ossicles do we have? 3 ossicles, malleus, incus, stapes. Middle one is malleus. Malleus has a process called short process. Short process of malleus. Now short process of the malleus comes and fits in a fossa here like this, and this fossa is called fossa incudis, because it is incus that is fitting here. So the name of the fossa is fossa incudis, this fossa. Why it's called incudis? Because incus comes and fits in this fossa, fossa incudis. So we have facial nerve with stylomastoid foramen, we have aeditus, the door, we have fossa incudis for the short portion of the incus, and now comes the three most important name from the posterior wall that you have to know. Which are these three very important name for the posterior wall that you have to know? One is called facial recess, I call it FR in short. The second one is sinus tympani, ST I call it, and the third is pyramid. Pyramid has a stapedius muscle. Remember two muscles I will discuss. This is the second muscle. Which is the first muscle we mentioned? Tensor tympani. Remember, from this canal here, anterior wall, there is a muscle called tensor tympani muscle, and now we will talk about another muscle, stapedius. So we have discussed three ossicles. We have discussed two nerves, facial nerve and tympanic plexus, and two muscles. This is the second muscle, right? I told you 6 walls. This is the last wall. 3 compartment we know, 3 ossicles we know, 2 muscles, we'll discuss one of them, and 2 nerves. So we have done everything. This is the last thing you have to do. Now look at the facial nerve on the posterior wall. It is going vertically down. Now one side of the facial nerve is sinus tympani, ST, the other side is facial recess, FR. So this side, this whole area is called ST area, sinus tympani, and the opposite side, this whole area is called FR area, facial recess area. So basically you can see on the posterior wall, your facial nerve is separating the facial recess from sinus tympani, right? And then there is a pyramid. Pyramid is a pyramidal shaped bone like this, a very tiny bone with the shape of this pyramid which I have drawn like this. And the importance is, like I have written also, from this pyramid a muscle will originate like this, and this muscle is the stapedius muscle. And all this is present on the posterior wall. Where exactly on the posterior wall? Look at the facial nerve, it is turning on the posterior wall. Below the turn, here there is a small pyramid like this. So this is a pyramidal bone like this, and from this bone a stapedius muscle originates like this. Pyramid with stapedius muscle. And can you guess which nerve will supply this muscle? Obviously a branch of the facial nerve goes and supplies this muscle. That is a very logical thing. And the name of the branch is nerve to stapedius. See, look at the name, nerve to stapedius is going to supply the stapedius muscle. But the point is, in the posterior wall of the middle ear, there is a branch also, facial nerve, called nerve to stapedius. Right. Now, stapedius muscle is a very, in the posterior wall, stapedius muscle is the most important structure. But before I talk about stapedius muscle, these are the names of the contents of the posterior wall. You know everything on the posterior wall in this slide, all the names. So talk about stapedius muscle. Where is the origin of stapedius muscle? Obviously the origin is pyramid, posterior wall. Where is it inserted? Where is the insertion of stapedius muscle? Why do you think this muscle is called stapedius? Why is the name like that? Because it is inserted into the neck of stapes. Stapes also has a neck, and because it is related to stapes, the name comes from there. If I ask you the nerve supply, I have already told you the nerve is nerve to stapedius, and this nerve to stapedius is a branch of 7th nerve. Yes or no? But the most important thing about stapedius that they ask you and you have to know is the function. So who will tell me the function of the stapedius muscle? Anybody? Boys and girls? Function of the stapedius muscle. Who wants to write in the comment in the Telegram group? Let's see. Anybody? I want everybody to write this because it's a very, very, very important MCQ. Let me see how many of you get it right. The function of the stapedius muscle on the posterior wall of the ear. Who are the takers? So only one person, Bharat, has written, and if you say acoustic reflex, Bharat, I will take that, but there's a better way of saying this thing. The same thing, you have to explain it better. What is a better answer? Who wants to say that? You have to say, the better way of saying is what Avi Mittal is saying. Dampens loud sound. It dampens loud sound. This is the function. Dampen means it decreases the loudness of the sound. If the sound is too loud, it will make it less loud. Why? Because loud sounds can damage the cochlea. And remember, in the beginning of the day when it started, I told you cochlea is the most important thing for hearing. If cochlea is gone, hearing is gone. Boom. Yes or no? And so there is a protection to the cochlea. And the stapedius muscle is like a protector of the cochlea. Everything is loud sound, it will dampen the sound, so the cochlea is protected. But how does it dampen? As many of you said, it dampens by producing a reflex called either stapedial reflex, because it is caused by the stapedius muscle, also called acoustic reflex, as many of you said. So it produces the reflex, and the reflex will dampen the loud sound. And these are the points about the stapedius muscle on the posterior wall that you have to know, right? Now, talking about stapedius reflex, like every other reflex, stapedial reflex also has an afferent nerve and it has an efferent nerve. And it's a very important MCQ that the afferent nerve is the 8th nerve in the stapedial reflex, and the efferent nerve is the nerve that supplies, which is 7th nerve in the stapedial reflex. So these are the two nerves in the reflex that are participating, 7th and 8th. One is afferent, one is efferent. Indirectly, it means for a normal stapedial reflex, along with the stapedius muscle, you need the 7th nerve and the 8th nerve also. And if any of the three are gone, whether stapedius muscle is gone, or 8th nerve is gone, or 7th nerve is gone, then you cannot have the reflex, and the reflex is absent. If it is absent reflex, that condition has name. It is called hyperacusis. So remember the meaning of this word hyperacusis. Hyperacusis is a term used where the stapedial reflex is absent, and it means either stapedius muscle is damaged, or 7th nerve is damaged, or 8th nerve is damaged, and this patient's cochlea is at risk now. If there is a loud sound, the cochlea will have no protection now, right? So these are the points about the stapedius muscle and the stapedial reflex that you have to remember. Very important. But coming back to this diagram here, look at the posterior wall now carefully. You can see so many things, including the facial nerve, and you can see a branch of the facial nerve also, nerve to stapedius, going to supply the stapedius muscle. But on posterior wall, there is one more branch of the facial nerve, which is very popular branch. Where does the branch arise? Just before the facial nerve enters the stylomastoid foramen, before the entry point, it gives rise to a branch like this. And this branch is CT. CT is chorda tympani. I'm sure you know chorda tympani is one of the most popular branch of the facial nerve. Now look at this posterior wall now. You can see the main facial nerve. You can see chorda tympani forming an angle, and little above that is this fossa inquiris, which I'm pointing with an arrow, right? Now the whole area between these three structures, this I'm shading now, this whole area is the facial recess area. So basically these are the three boundaries of facial recess. Facial nerve, chorda tympani and fossa inquiris are the boundaries of the facial recess, FR. So if I write here facial recess and three boundaries is facial nerve is one boundary, chorda tympani is the second boundary, it's a branch of facial nerve, and fossa inquiris is the third boundary. So these are the points about facial recess that you have to know. On the other side there is sinus tympani, isn't it? Now what do you have to know about sinus tympani, which is on the other side of the facial nerve? You have to know this, that surgery is difficult here in sinus tympani. You cannot do surgery in the sinus tympani. It's difficult. Meaning, if somebody has a disease in the sinus tympani, like cholestoma, even after the surgery, the disease cannot be removed. It will remain behind. And the disease that remains behind after the surgery is either called recurrent disease or it is called residual disease. That is, which is left behind. That means, if I ask you in which part of the ear is recurrent or residual disease most commonly seen, the answer is sinus tympani in the posterior wall, isn't it? So these are the 2 points about facial recess and sinus tympani. And this will complete your posterior wall of the ear also. That means we have done all the 6 walls of the middle ear, 3 compartments, 2 muscles, 2 nerves and 3 ossicles, and this is the anatomy of the middle ear that you have to know. Very important anatomy, not very difficult, but very commonly asked in the exam. I hope it is clear to you and you can remember when they ask you a question, you can answer them. Now look at this diagram. The red arrow is the Prusac space. So if that red arrow is the Prusac space, you understand that this is what? This is the lateral malleolar fold. And what is this? This is the neck of malleus. What is this? This is pars flaccida, and this bone above the pars flaccida is the scutum. This is the scutum, which is also on the outer wall boundary of the Prusac space. Remember, outer wall of the Prusac space is pars flaccida, which is this one, and scutum. And this space is the most common site of cholestoma. Now, the normal tympanic membrane, I had shown you the image already, looks like this. This is a normal tympanic membrane. Now, look at this membrane. This is how a retracted tympanic membrane looks like. In a retracted membrane, along with this malleus, this is the malleus, you can see the incus and the promontory also. This is the malleus in the second diagram, this is the incus and this is the promontory. So in the retracted membrane, you can see other things also. And this is a middle ear with perforated tympanic membrane. And right in the front, this bulge is promontory. This is the promontory bulge. And this ossicle, which can be seen small, this is the malleus, handle of malleus. So these are the things that you should be able to identify easily in the image of the middle ear. I will show you more images of the middle ear, more structures. But since we have completed the middle ear, I think you guys deserve a break here. Okay, we'll take a break here for 30 minutes and we'll come back and continue with the anatomy of the ear. Okay, so please take break.